In terms of my background, I'm born and bred here. Talmatora, Herzliya, went away for a couple of years for school, came back to McGill, did emergency medicine at McGill, did my specialty training here, started off at the General, St. Mary's, now at the Vic. So I've been here for longer than I cared. Let's just say I'm the class of '79 in medical school. I've been practicing emergency medicine since '82. Enough said. That gives you some indication. I'm not the youngest guy on the block. What I came here to do is actually talk to you a bit about what the emergency room is good at. And in fact, the title of the talk is, you know, the emergency room, everything you maybe shouldn't be asking or wanted to ask but never had the opportunity to find out about. And that's what I'm going to talk to you about. But I want to emphasize something that has already been said. I'm really set up as an acute care trauma or acute care illness facility. And I'm really set up to do some things really, really well and a lot of other things really, really badly. So if you're an older person and you really don't need to be in my emergency room, dimes to donuts, I'm going to make you worse rather than make you better. And I deal with this all the time. The nursing homes that don't have the facilities that are available here, that don't have the expertise that's immediately available here, that just send their patients in. They're there for days at a time, getting minimal nursing care because I don't have the staff. And my staff is busy with the new ones that keep coming in. They develop the secondary infections, the confusion. My lights are on 24/7, right? I'm 24/7. I can't turn off the lights at night so you can get a good night's sleep. There's noise, there's hustle and bustle. If you've ever been to our emergency rooms, you know that dimes to donuts, you're in a corridor with your butt hanging out in a half-fitting Johnny gown with air conditioning, so you're cold, there aren't blankets, there aren't pillows. I say this not because I'm proud of the environment in which I work. The reason why I stay on in emergency medicine is I believe we all have something that we can contribute to make it better. That's why I do what I do. Be very easy to walk away. We stay, those of us who've stayed on for 10 or 15 or 20 or 30 years, do it because we think we can make a difference. Having said that, if you don't have to be in the emergency room, don't go. End of sentence. And if you're lucky enough to have a loved one who's in this place, as an example, where they have just about everything they need to make a diagnosis, decide appropriate treatment, start even intravenous therapy if necessary, the occasions where you should be seeing me in the emergency room at the Royal Vic or the Jewish or St. Mary's should be really teeny, 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 teeny. And that's, if there's no other message to get out here, I think that's really an important message to understand. So let's talk about things. When should you go to the emergency room? When should you go to the emergency room? So what would be something that you should go to the emergency room for? You think you're dying. That's a good one. How do you know if you're dying? So if someone collapses in front of you and they aren't talking, this is not just a moment when you call for an ambulance. You should be doing probably CPR. This is just an aside. And by the way, all of you should know how to do CPR. Even the oldest and most infirm amongst you probably are capable of doing good CPR. Remember, you no longer have to do mouth-to-mouth. Gone are the days where we have to do mouth-to-mouth. You don't have to worry about spreading an infection that way. You can just pump on their chest and do a lot of good. So that's a big change in the last couple of years. So if someone looks like they're dying, but before they're dying, what else?
If you fell and cut yourself,
yeah. So a fall, the answer here is a fall. A severe fall where the person isn't able to move. Can't move their hip, can't move their arm, right? It's deformed, it's out of position. Or they hit their head severely. They're a bit confused after they hit, or they're bleeding. These are all legitimate reasons why you need to be seen. And then we'll debate about whether you should call urgence santé. That's another side. We'll get to that. So severe chest pain. Right, someone who suddenly develops chest pain, you know, the classic, right, the classic signs of a heart problem, you know, the crushing retrosternal chest pain that may radiate down into your left arm. You break out into a cold sweat, you can't catch your breath, and you're sure you're going to die. Well, that's real. Unfortunately, that only happens in a small percentage of middle-aged guys. And that's why that was the classic sign of a heart attack way back when, because who did we take care of? It was guys taking care of guys. Right? And that's what always presented. Nowadays, we've realized that heart attacks can present in a much more subtle way. So if you're female, you're not really likely to present with crushing chest pain and all of that. You're more likely to present with sudden unexplained weakness. Every day I get up, I can walk this distance. I'm walking, and all of a sudden, I just can't do it. I just haven't got the koyach. I haven't got the strength. I can't do it. That's a warning sign. Sudden shortness of breath, unexplained by something obvious. You know, so sudden weakness, sudden shortness of breath, a faint under the wrong circumstances, these all set off alarm bells in women and in older people. Older people as well may not present with the classic chest pain. So if you pass out, if you're suddenly a lot weaker than you would normally be, if you can't catch your breath and you normally can, or if you're having that crushing retrosternal behind the breastbone chest pain, good reasons to be seen in an emergency room. We'll discuss how you get there if I remember in a few minutes. So we talked about being dead. We talked about a fall. We talked about signs of a heart attack. There are other good reasons to come to an emergency room, and they're very prevalent right now. You may have grandchildren or yourselves. The old gastro, we used to call it stomach flu. You realize it's not really influenza. It's not really a flu, but it's usually a virus. But they have the nausea, the vomiting, and the from the other end, right? These are legitimate reasons to be seen in an emergency room if they have a high fever at the same time, if they can't keep up with their fluids, so you know that they're getting dehydrated, or if they're vomiting blood, or if blood is coming out the other end. Again, I'm being videotaped, so we won't use the term for it, but the other end, I think you'll get my meaning. Now, blood, when it comes out, is not always red. If it's had enough time to get digested by your body, it actually turns sort of a tarish black color, sort of maroonish black. We call that melena or melena, depending upon your linguistic preference. And it has a very characteristic aroma that I will not share with you, but it's strong. So if someone has nausea, vomiting, and they can't keep up with their liquids, or they have underlying kidney or heart disease and they're on medications, or they're very old or very young, okay, and we can't start intravenous like you could here, or if they're vomiting blood or blood's coming out the other end, good reasons to be seen in the emergency room. That brings us to the other group of reasons to come to the emergency room. A high fever that persists, and especially if it's associated with confusion, irritability, a change like somnolence. These are also warning signs, and if they have a stiff neck. And the last thing I'll mention, I'm sure I've left out something, is a severe headache. Bango! The worst headache you've ever had in your life, especially if it's associated with other symptoms or signs, perhaps weakness, or a problem with vision, or a stiff neck. We call this a thunderclap headache. It could be a sign of a subarachnoid hemorrhage. You may have heard of that young Bishop's football player that no one saw anything happen to him. So the question is, was it a hit, and this is a concussion, and then a bleed? Or did he actually just burst an aneurysm, a subarachnoid bleed, spontaneously on his own? Anyone can do that. There's a certain percentage of us that have an abnormality of the blood vessels at the base of our brain, and suddenly, without any warning, whether you have high blood pressure or not, has nothing to do with that, it goes pop. Actually, you can sometimes hear the pop. The patient can say, I heard a pop, and then suddenly I had the worst headache I've ever had in my life. I thought I was going to pass out. I was nauseated. I vomited. And sometimes it'll get a bit better, so they think, it's nothing. It's a big mistake. They should be seen in the emergency room. So fever, change in behavior, sudden unexplained headaches, chest pain, dying. I think we've covered most of the obvious things. Now, I would tell you, if you don't have any of those things, you shouldn't come to the emergency room, but you're going to say, okay, where should I go? This is a very legitimate, a reasonable question. In the old days, we had people called family doctors. And these family doctors, a rare species that we rarely see anymore, worked on their own. They had an office. You usually knew the secretary or nurse. You called up, and the doctor says, it would be a pleasure to see you. Why don't you come at the end of the day or now or whatever, right? Now, 20% of Quebecers do not have a primary care physician, even though they want them. The most frequently asked question I get is, Mitch, can you get me a doctor? Most frequently asked question I get all the time. And so they don't have a primary care physician. And if they do have a primary care physician and they're not calling during usual office hours, actually even if they are calling during usual office hours, the answer is, sure, I can book you an appointment in 2013, if you're lucky. Right? So what are your options? In all honesty, what are your options? And that's why all these commentaries about how the emergency room is being abused, it's not being abused. People aren't being given a choice, to be honest with you. So the Quebec government, to deal with this, set up what they call the clinique réseau. And so what they've set up is clinics all over the place. There's also the CLSCs, and there's these standing clinics. My comment to you would be, I have no problem with the stat cares and the standing clinics of this world, none whatsoever. But I would suggest that you should know what they're able to do before you get there, and what their hours are, and whether they have doctors. So example, you fall, you think you've broken your wrist, before you go and spend 17 hours waiting in the emergency room. By the way, you should go to the general and not to the Vic. the MUHC has split up its services. So I do not have orthopedic surgery at the Royal Victoria Hospital. You come with your broken bone, you're taking a chance on me, and then I refer you over to ortho at the general. So if you think it's a broken bone, that's where you should be going. St. Mary's has their own orthopedics, the Jewish has their own orthopedics in-house. Having said that, you've fallen. Your wrist, I'm not sure, maybe it's broken, maybe it isn't broken. All I really need, doc, is an x-ray. If you go to the clinic and the clinic doesn't have x-ray facilities, you're wasting your time, although you're enriching them, and they're still going to send you to me to get the x-ray, right? So my comment to you would be, know what's available within your community, your area, have resources available. Talk to your doctor. Say, if this happens, what do you want me to do? A lot of family docs, and I was kidding before, a lot of the family docs who are still around have very good setups. There are certain doctors, I never see a patient in the emergency room from these docs because they take such good care of their patients, or on those rare occasions when they're sending me a patient, they call me in advance. They'll say, Mitch, I'm sending in Mrs. So-and-so, this is what I think is going on. Could you do the following? What a big difference that makes. Huge difference. Which brings me to another key point. Should you be seen by your family doctor, by a doctor? Doctor says, I'm sorry, I need to send you into the emerge, and they give you this little piece of paper and you think, great, I have my Willy Wonka ticket, I get in, right? Wrong. You come to triage, the nurse looks at this note, assuming anyone can read it, very big if, and they go, so what? And you go into the queue. The problem is, unless that doctor has been intelligent enough to make the effort to call the specialty service that he wants, or to call me, you're treated like anyone else who comes in the door. So very important that the doctor calls ahead, either to me in the emerge, and I'm very reachable. We all walk around with Spectral Links, special phones that go directly to us. We're very reachable in the emergency room. Or he speaks to the service. Looks, he really wants orthopedic surgery to see this patient. He calls ahead, speaks to the orthopedic surgeon on call. There's always someone on call. And says, I'm sending in Mrs. So-and-so to the emerge. When she gets there, what do you want me to do? And the orthopedic surgeon may say, just tell them to call me and I'll come in. Or he may say, have them get an x-ray and then call me if they need me. But things are teed up. So you come in with your piece of paper, but you say, my doctor spoke to Dr. X in orthopedics who asked me to do the following things. Or my doctor spoke to Dr. Shulman in the emergency room who's expecting me. Now, do you walk to the head of the line? No. But I can guarantee that your stay in the emergency room is a lot quicker and a lot more efficient. One of the key problems is how you're going to deal with the ambulance. So if you're going to call urgence santé, you do it because you have to. If someone's fallen and broken a hip, you don't have a choice. You have to call urgence santé. You're not going to take them. If someone's had a cardiac arrest, you're not bringing them in on your own. I don't see how you can do CPR in your car while you're driving. It looks bad. Also, if they're vomiting and doing all these other things, you're not going to want to bring them in your car. So any situation where they're really, really sick, it's not even a question. You've got to do what you've got to do. But if there's a debate, so my best friend, one of my best friends called me the other day and said, you know, my elderly mother fell. She's been walking around, but she's complaining a lot of chest pain, we think she's cracked a rib. Should I call an ambulance? And my comment to him was, where is she known? He said, the Jewish in St. Mary's. I said, how bad is she? Does she look really bad? Is she having trouble breathing? And he says, no. I said, if you don't feel comfortable, call an ambulance. But I don't know how long the ambulance will take to get to you. Maybe low priority. There may not be a lot of ambulances. And you won't have control over where she goes. Why don't you take her to either the Jewish or St. Mary's? He ended up taking her to the Jewish. So, you know, I don't want to put anyone at risk. And I certainly don't want you transporting someone who could have a cardiac arrest because of chest pain while you're transporting. This is not swift. But if in doubt, I would take control of that into my own hands so that I bring them where I want them to be. And I would strongly urge you to do that. Okay.